Welcome, everyone. Thank you so much for joining us tonight for this virtual UMiami Health Talk. Advances in cardiac care, innovations in heart disease prevention and treatment, a hot topic tonight. Many of you are joining us this evening. I'm medical journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by UHealth's Cardiac and Vascular Program. Our experts pioneer and advance the latest diagnostic, minimally invasive, and surgical procedures. They offer multidisciplinary care and the latest innovations for heart disease prevention, heart failure, atrial fibrillation, interventional cardiology, and so much more. UHealth is also home to the only American Heart Association certified hypertension center with access to the latest breakthroughs in research, world-class treatments, and of course, personalized care. To learn more about our cardiovascular services, please visit umiamihealth.org/cardiovascular and call 305-243-5554 to schedule a consultation and screening. Do not worry, those numbers, that information is going to be repeated. And if you want to take a second right now to take a picture of the screen and keep it, but you're going to hear it again. And you're also going to get a copy of this webinar soon after we finish, probably about a week or so later. Anyway, let's begin with our experts tonight who are going to discuss the latest innovations in heart disease prevention and treatment. The topics will include understanding long-term heart health, how estimating 30-year risk can help prevent heart disease earlier, new treatments for lowering cholesterol and improving heart health, and the latest research on reducing heart disease risk, including the role of lipoprotein A. At the end of the presentation, there's going to be a Q&A session. Now, this is a unique opportunity for you to ask direct questions of our experts. Don't take advantage of it. Use the Q&A feature at the bottom of your Zoom screen to enter your questions. Take a look at your screen. We're going to prepare them for our panel to address. So let's begin, and it's my pleasure to introduce our very first speaker, Dr. Yannis Hatzisisis, an internationally recognized, board-certified interventional and imaging cardiologist and chief of the Division of Cardiovascular Medicine at the University of Miami Miller School of Medicine. Dr. Hatzisisis has received more than 40 international and national awards, among many other accolades. Let's welcome Dr. Hatzisisis to launch our evening.
Thank you so much, Ileana. Very thrilled to be here tonight. We're going to have this unique opportunity to meet with the experts and discuss about prevention. What is more important than prevention? By prevention, we save downstream events and we improve the outcome. So it's very important that we engage in cardiac prevention to live better and longer lives. I'm gonna take a moment here and share with our esteemed attendees a couple of words about who we are. The Cardiac and Vascular Program, the Division of Cardiology at the University of Miami, which are our strengths. We operate in a system which has a very visionary and very executive leadership at the University of Miami Miller School of Medicine level, and of course at the UHealth, University of Miami healthcare system level. We have the fortune to collaborate with a very skillful faculty and staff, and this makes a difference. The human factor makes a difference in the services we offer. We operate in world-class research and clinical centers and institutes. We have access to an extensive clinical and research infrastructure. And of course, we are under the umbrella of the premier academic ecosystem of the University of Miami. And also very important to highlight that our healthcare system is quite wide. We offer our services, our mission to help our community live better and longer life at the neighborhood. The concept that we apply is that we go to the neighborhood to serve our community versus having the community come downtown to the busy hospital. This way, we have deployed a network of multiple medical centers across the entire Tri-County area. I have them here summarized all the way from the Monroe County to Palm Beach County. And I would like to emphasize, to highlight the three major flagship medical centers where we offer cardiovascular care to our community in Lennar, down south in Coral Gables, Doral, west to the airport, which just opened, and of course, Solemia, north in Aventura, Sunny Isles area, which is about to open in the next few months. What is our mission as a cardiovascular program? First of all, to offer the finest clinical care, to undertake world-class research and bring innovation, to provide to our trainees excellent education and training, to integrate digital technologies, very, very important mission nowadays, to streamline our care and offer services, and of course, to collaborate with academia and industry in this way to stand out locally, regionally, nationally, and internationally. And this summarizes the model of our clinical care. We offer programs, new programs, impactful programs, who focus on top-class quality and outcomes, which bring innovation. And of course, we put special emphasis on augmenting our reputation and growing. And this applies, this clinical care model, all the way from prevention, and you're going to hear more about this tonight, to diagnosis and, of course, to therapy. And speaking about clinical programs, this is a summary of our clinical programs that we offer. All a big variety, starting from prevention to coronary disease therapy, to valvular and structural heart disease, to aortic and peripheral disease, to electrophysiology, and of course, heart failure. Preventive cardiology is a key operation. And as you can see here, now it's highlighted in our operations as top-class priority. It's a new program. We have the fortune here to host under the preventive cardiology program the hypertension center, among the very few in the country, American Heart Association certified hypertension centers. We have nutrition services there. We have lipidology experts, genetics experts, and of course, access to endocrinology with emphasis to diabetes and obesity. And bottom line is that every man older than 40 years and every woman older than 50 years in this beautiful community should have access, one way or the other, to preventive cardiology, should have a cardiac checkup. And that's the message I would like to send. And we have this kind of services through our comprehensive preventive cardiology program offered to our beautiful community. Imaging, very, very important. Advanced cardiovascular imaging, as we call it, cardiac CT, cardiac MRI, nuclear cardiology. We offer these services in our comprehensive imaging program. As you can see, we offer these services not downtown only, but in the decentralized model close to each neighborhood. And we offer calcium scores. We offer fast appointments, high quality imaging, and of course, the latest technologies for cardiovascular risk prediction. So very, very important ally in our preventive cardiology mission and operation, the access to advanced cardiovascular imaging through our services. And finally, heart failure, the pandemic nowadays, heart failure becomes a global problem. We offer through our partnership with Jackson and Miami Transplant Institute a very comprehensive heart failure program, which spans all the way from advanced mechanical support, cardiac transplantation, to cardiomyopathies, to hypertrophic cardiomyopathy, to genetic cardiomyopathies, to pulmonary hypertension, to cardio-oncology. All those are important pathologies which are tackled in a very seamless and a very comprehensive way in our global and holistic heart failure program. So all in all, we are here to offer top-class quality of care in the region, in our community, offer unparalleled patient care, offer first-class education to our trainees, be front runners in terms of research and innovation, and of course, set the standards when it comes to quality of care and compliance. With that, I would like to, again, to thank you so much for hosting us here tonight. And we're going to pass it to Dr. Bromley, who's going to go deeper into what kind of services we can offer with in terms preventive cardiology and why preventive cardiology is so important. Thank you so much.
Thank you so much, Dr. Hatzisisis. I'm going to take it and then toss it over to Dr. Bromley. But how important for all of us to realize that this is not in only one centralized place in downtown in the Civic Center where everyone thinks. The fact that it's spread out all over the community is what makes it accessible to everyone. So wonderful message, and I think everyone listened. All right, let's tee up our next speaker, Dr. Andrew Bromley, a native South Floridian who completed his undergraduate studies at the University of Miami. After his medical residency, he returned home to South Florida to complete his fellowship in cardiology at the University of Miami and Jackson Memorial Hospital. Dr. Bromley is the director of our outpatient clinic and treats patients with a wide spectrum of cardiac conditions, including hypertension, hyperlipidemia, coronary artery disease, valvular disease, diseases of the aorta, and congestive heart failure. Dr. Bromley is board certified in clinical lipidology. Take it away, Dr. Bromley.
Thank you so much. Thank you for the lovely introduction, and thank you for having me. I'm going to go ahead and just share my screen. I'm going to enlarge it. Okay. So yes, it's great to be here, and I'm super excited to be chatting with all of you about a topic near and dear to my heart and one that I'm very passionate about, the prevention of cardiovascular disease. So we have, over the years, gotten quite adept and quite good at treating cardiovascular disease. The next frontier within the role of us as cardiologists to you, the general public, is to help prevent cardiovascular disease so that we can hopefully put my boss, Dr. Hatzisisis, an interventional cardiologist who treats coronary disease once it has gotten to its ultimate point, out of business, so that stents and the procedures that ultimately complicate the end stages of cardiovascular disease out of business. I tease him when I say that, I jest with him, but that's the goal in preventing cardiovascular disease. So when we talk about cardiovascular disease, what exactly is it that we're talking about? The heart, in essence, is an organ that pumps blood to the rest of the body to allow oxygenated blood to reach the critical organs that require oxygen to do their functions of daily living. Cardiovascular disease is an umbrella term that can apply to hosts of processes that can involve any sort of dysfunction within the pump. So you can have heart failure where the pump itself is not working the way it's supposed to, either in the way it pumps or relaxes. You can have issues with the valves in the way that the valves open and close, where they leak or they don't open the way they should. And so that blood can't move in the heart the way it's supposed to. Our heart is set with an electrical circuit that tells the heart when to pump and in what coordinated way to do that. And you can have electrical issues. Those can be arrhythmias, such as atrial fibrillation, or many other types of electrical diseases. Lastly, you can have disease or issues with the layer of tissue that surrounds the heart, the pericardium, that can present with inflammation and cause problems there. The type of heart disease that we're going to focus in on today is coronary artery disease, and that's a disease of plaque development within the arteries of the heart in most instances. Prevention of cardiovascular disease can apply to a host of different types of disease, but the one that we'll make the greatest efforts to prevent with forms of cholesterol lowering that we're going to talk about is really in regards to atherosclerotic cardiovascular disease. And that's the buildup of plaque within the artery of your heart. That can happen in the heart arteries. It can happen in the arteries of the carotids, within the neck, within the aorta, throughout your body, and in the legs. But as a cardiologist, the one I focus in on the most is within the arteries of the heart. Plaque is a process that happens, plaque buildup, early on in life for many people. It starts happening as early as childhood, in your teens. By 20s and 30s, many people have started to develop fatty streaks of cholesterol within the arteries of your heart. It's oftentimes not later on, until an individual reaches their 40s, 50s, or 60s, that we start to see signs of plaque, often in the forms of calcification that forms on those arteries. And that's oftentimes when someone becomes aware of that, be it they see the calcium on a CT scan, or unfortunately, once it's too late and they've already presented with a cardiac event. My hope in sharing this slide with you is to just relay that the process of atherosclerosis begins early on in life. So the focus of prevention should also be one that started early on in life. When we talk about prevention, there's different ways of thinking about the prevention model. Oftentimes, when we're talking about prevention, we're seeing patients once it's too late. That's referred to as secondary prevention. Patients have had a heart attack, they've had a stent placed, they've had a stroke. They've come to see us now in efforts to reduce their risk, improve their risk factors, so that they can prevent a second or a third, or in instances, a fourth or fifth event. It's at this end of the pyramid that we still need to make efforts, but it's, in my opinion, far too late for that individual. Primary prevention is someone who does not yet have disease. They may have risk factors, cholesterol, elevated blood pressure, diabetes, the metabolic syndrome, and I'll get into what exactly that is, but those are people who stand to be at increased risk for developing disease. It's at this point in life that I, as a preventative cardiologist, will often see patients who don't have cardiovascular disease, but we'll see them to kind of work through those risk factors, try to see what your risk really is, and determine how best to go about addressing the factors that can contribute to the development of atherosclerotic cardiovascular disease. Where we're moving as a field, and hopefully as a country, is thinking about prevention in regards of what's termed primordial prevention. And that's something that's ingrained into society from birth and throughout life, and affects the way we live from day to day, the way we commute to work, our exposure in the environment to environmental pollutants, the maintenance of healthy body weights, getting enough physical activity. It's the way as a society we structure our lives. That's ultimately the goal of preventative medicine at large, is to structure life so it's healthy for all. But this is really the spectrum of how prevention is thought of within the cardiovascular space. When we talk about prevention, there are risk factors that we can modify and those that are more difficult to modify. The ones that we can't well modify are our genetically inherited risk factors that we receive from mom and dad, and our environmental exposures that we're exposed to with where we work and where we live. Those are tough to influence. The ones that we can modify are termed Life's Essential 8, and that's put out by the American Heart Association. And these are 8 risk factors that all of us should keep in mind and are things that we should address. 5 of them have to do with, well, 4 of them have to do with the way you go about your daily living and take into consideration your activity. 4 of them have to do with blood tests and weight. I'll go through these 8 because they're of critical importance for things that you can do outside of seeing a cardiologist, through work with your primary care doctor, and in your own living. Tobacco use is number 1. If you're on this chat, I suspect you're in tune in your health and you're engaged. You're likely not smoking. But if there is anyone on this call who is smoking, or you have loved ones who are smoking, the single biggest thing you can do to improve your long-term health is stop smoking. And that's really the biggest takeaway from this. Sleep is critical. Getting at least 7 hours of high quality sleep is of the utmost importance. High quality meaning that you don't have sleep apnea, that you're waking up rested, energetic. Eating. This is a very contentious topic, and one that could take well over an hour to address. The big takeaway I want to leave you with is there is no one perfect diet that fits all. I'm a believer in moderation. A diet that is as whole, unprocessed, unrefined, avoiding ultra-processed foods, and as prepared from home and not restaurants or takeout is ideal as possible. We can get into more specifics of what that should look like, but keeping in mind a whole unprocessed home-cooked diet is what you should be striving to eat. Activity. Activity is critically important, and a sedentary lifestyle is really disastrous with regards to cardiovascular disease. 150 minutes or 2.5 hours of moderate intensity exercise is what you should be aiming for over the course of a week. Managing your weight to avoid obesity is very important. Now more than ever, there are a number of options, both surgical, pharmacologic, and others, to help get weight to goal. So we have more than ever now to get there. And then finally, with your doctor, working to manage your blood sugar, blood pressure, and blood cholesterol. Myself, as a lipidologist, I have a particular interest in cholesterol, and in clinic often help work with patients to get cholesterol to where it should be. Question often becomes is, where should your cholesterol be? That is a question that is very patient dependent, and it differs from person to person. Not every single human being has to be or should be at the same exact cholesterol level. Where your cholesterol should be is largely determined by your risk. Your risk for cardiovascular disease can be estimated or calculated using a number of different calculators. We have what are called pooled cohort equations, which are calculators that look at a number of risk factors, cholesterol, but others like blood pressure and diabetes and family history and kidney function, etc., to try to calculate what your risk of disease might be. Historically, we've been limited with calculators that were only able to prognosticate risk out 10 years. That limited us because many calculators weighted patients who were younger, in their 30s, 40s, or even 50s, as having lower risk and may have underestimated the degree of risk. Newer calculators, like the PREVENT calculator by the American Heart Association, allows us to prognosticate risk starting in your 30s and prognosticate for 30 years out. That's helpful because I see many patients who are in their 30s and 40s and may have some risk factors. And when we prognosticate risk over the longer term, find that they really are at higher risk over the course of their lives, as opposed to just in their years of their 30s and 40s. And what we're looking to do is mitigate risk over the course of your lifespan, not just in your 30s, 40s, 50s, or 60s, but throughout your life. So when we talk about risk, there are different pools of risk. This is a busy chart, and I don't expect you to commit this to memory, for you to commit it to memory, but your doctor needs to commit it to memory. The focus of this is that there are different degrees of risk based on the numbers that get spit out to us by different calculators. Broadly speaking, elevated risk is when your risk of a cardiac event, like heart attack or stroke, is estimated at more than 20% over a 10-year or 30-year period. Low risk is less than 5%. There's a gray area of a borderline or intermediate between that 5 and 20%. This is important because patients who get prognosticated to have low risk at less than 5% tend to be at overall low risk of an event, and those patients may not require treatment of their cholesterol as aggressively as others and may not even need medical therapy. That's applicable in patients sometimes who have borderline or moderate cholesterol that has been on the fence about treating. And sometimes I see patients and we come up with a decision that based on their risk, they may not need medical therapy. Those who are at high risk do benefit from being on cholesterol lowering medication. Finding what the right solution for that patient is one of working with a physician to find what's right for you. But patients who are at elevated risk certainly stand to benefit. And the reason for that is because we know that lowering cholesterol, every LDL cholesterol, lowering at 38 milligrams per deciliter, translates roughly to a 22% reduction in risk of a cardiac event. So if you have a really high cholesterol and you can lower it 80 points, you've dropped your risk of an event by approximately 44% of a cardiac event over that 10-year period. That's substantial. So if you come in and you have a 25 or 30% risk of an event, we drop you by 44%. I've dropped that 10, 15% of a cardiac event. That's a meaningful benefit that you stand to gain. Where that's more in question is in that intermediate range. And if you fall in that intermediate range, there are a number of things that your doctor may decide to explore with you to help figure out what the right step forward is. We have coronary calcium CT scanning, which is a way to get a sneak peek of what I showed you in that earlier slide, which is the illustration of the buildup of plaque that is already starting to develop within the arteries of your heart. There are other things that need to be explored beyond the conventional risk factors of just blood pressure, blood sugar, and blood cholesterol. There are what are called risk-enhancing features. And these are things that may not be obvious risk factors to you or to others that your other providers you're seeing, but are well-established risk factors that also lead to elevated risk of you developing disease and are such that should be a light bulb to those taking care of you that you might stand to benefit from looking at your risk factors and potentially lowering cholesterol. A significant family history of premature atherosclerotic disease certainly raises alarm bells for me. The metabolic syndrome, which is a combination of central obesity with an increased waist circumference, insulin insensitivity, or resistance, diabetes. Chronic kidney disease is certainly tied into the development of atherosclerotic disease at an accelerated pace. Inflammatory conditions like rheumatoid arthritis or lupus are underlying inflammatory conditions that can cause endothelial damage or a disruption to the lining within the artery of your heart, making it more accessible for cholesterol to deposit within the lining of the arteries of your heart. Particularly for women, complications of pregnancy like preeclampsia, gestational diabetes, or high blood pressure or hypertension during pregnancy are risk-enhancing features, and premature menopause before the age of 40. Additionally, there are a number of biomarkers that you may or may have not had checked before. Lp(a) is something I'll touch on, and apolipoprotein B are different cholesterol markers or tests that you may have not had checked before that may suggest you're at elevated risk, even if your lipid panel or your traditional cholesterol panel doesn't seem to suggest risk. And we'll touch on some of those. So the question often becomes, is where should your cholesterol level ideally be? And the answer is, that's a difficult question to answer in that it's very dependent on who you are as an individual. That's a discussion that should happen between you, your provider. Your provider should take into consideration what your risk is, calculate your risk, and based on that degree of risk, assign a goal. That goal, broadly speaking, is determined by the degree of risk, in that the higher the risk you are, the lower you want your cholesterol to be, because the higher you are, the more you want, the more benefit you stand to gain in reducing it. Within the lipid panel, it's the LDL cholesterol that is most directly tied to the development of plaque within the arteries of your heart. So as a cardiologist, it's the one that I pay particular attention to. We have cutoffs of 55, 70, 100, and potentially 116 for individuals who are at very high, intermediate, or low risk. Don't expect you to know all those numbers, but I say it to say there is no one perfect cholesterol of where you should be or where everyone should be. It's a really individualized decision process that hopefully you could see takes quite a bit of thought and calculation, and is highly, highly individualized. So you see a provider, you have risk, and you have high cholesterol, and a decision is made to lower cholesterol. You're told you need to be on cholesterol lowering medication. This is a bit of a complex slide, but I show it to you to show that cholesterol lowering happens through medications in a number of different ways. Historically, we were limited for many years to statins, other therapies, but now in 2025, we have more available to treat LDL cholesterol than we've ever had before in human history. Broadly speaking, we have 4 main groups of drug classes that treat cholesterol. 2 of them block the liver's ability to produce cholesterol. Those are statins and a non-statin alternative, bempedoic acid. That's going to prohibit or lessen your ability to make cholesterol. One of them, ezetimibe, is going to block your intestinal ability to absorb cholesterol in your diet and in other ways. And the last group of drugs are a group of drugs that enhance your body's and your liver's own ability to clear cholesterol from the bloodstream. And those come in a form of an injection. So we have injections, we have pills, we have some that are every 2 weeks, some that are every 6 months. We have a number of options, and we have more than we have ever before. So now in 2025, there's less excuse than ever before to not get your cholesterol to where it needs to be, because we have so many different options to get you to where you need to be to mitigate and lower your risk. I want to end on where we're going with the next frontier of lowering cholesterol. And I want to introduce lipoprotein A, or Lp(a). We've gotten really, really good at lowering LDL cholesterol, and I'm confident in saying that the vast majority of people on this call, given trial and error, can get to where they need to be on their LDL cholesterol front. Lp(a) is the next area where we need to make that same progress on. This is a type of LDL cholesterol molecule that is not excuse me, that is not directly measured in your traditional lipid panel. It makes up about 20% of all of your LDL cholesterol. The molecule itself is an LDL cholesterol molecule that has an additional chain on it, an apolipoprotein A chain that makes it and distinguishes it from the rest of your cholesterol. It's unique in that 70 to 90% of the volume of Lp(a) that you have in your body is determined by the genes that you've inherited from mom and dad. So that regardless of the exercise you're doing or the diet you're maintaining or the weight you've lost or the other medications you're taking, you're unlikely to make any meaningful impact on the levels of this lab marker. This cholesterol is particularly atherogenic, meaning prone to develop atherosclerosis or plaque within the arteries of your heart. It's also the most commonly inherited cholesterol disorder we know of. 1 out of every 5 individuals has an elevated Lp(a) level. There are a few different ways to check this laboratory value, but a normal lab is below 75 nanomoles per liter, and that's where 80% of the population lies. But about 20 have an elevated level. 75 to 125 is considered intermediate, whereas 125 and beyond to 600 is considered elevated. And it's the most commonly inherited cholesterol disorder that does contribute directly in a causal fashion to the development of plaque within the arteries of your heart. The discouraging news is that at the moment, there are no FDA-approved medications to directly treat and lower Lp(a). The encouraging news is that there are a multitude of phase 2 and phase 3 trials that are underway that look at 3 different drugs and more that lower Lp(a) robustly, 80 to 90%. I'm also excited to share that starting in May, we're going to be enrolling patients here in a drug trial for pelacarsen here at the University of Miami's Lipid Clinic, a medication that lowers Lp(a) by 80 to 90%. And we're going to be enrolling in patients who have established coronary disease with a history of cardiac events, who have high cholesterol and have high Lp(a). But the future will hopefully be that patients who do not yet have heart attacks, stents, and bypasses will hopefully be able to receive treatment with these drugs in the coming years to also get out in front way before the event and lower this cholesterol way before anything happens. So that's kind of a gist of where we're at with cholesterol and prevention. And
Thank you.
happy to, yeah.
And before we're about to launch the Q&A session, everyone, but since we ended on the Lp(a), can any regular physician, your primary care physician, test for that when they do the panels for cholesterol, or only centers such as yours?
No, that's a great question. So anyone can ask any provider to order it. LabCorp, Quest, the major labs out there have up and running. They check it. So you can ask your cardiologist, you can ask your doctor, if you can go ahead and have that lab checked.
Great. Thank you for that information. I think we're all learning in leaps and bounds tonight. So now that we've launched the Q&A session, let's begin with the first question. Some of these were sent in advance. So here's number 1. What's the actual difference between elevated cholesterol from the food you eat versus the amount of cholesterol your own body produces?
That's a great question. And it's one that actually has undergone a bit of a change in thought over the years and over the decades. If you look at dietary guidelines released a couple of decades ago, there were pretty strict, descriptive recommendations of exactly how much dietary cholesterol we should be taking in the course of our diet. And if you look at more recent guidelines, as recent as 2020, those recommendations have actually gone away, and there is no formal recommendation anymore with regards to how much dietary cholesterol you should be limiting yourself to. That stems from a change in thought of how we think about where cholesterol in our bloodstream comes from. And it's a movement away from dietary cholesterol in the form of eggs, butter, milk, etc., and thinking more in regards to saturated fat. The reason for that is because on an individual level, the individual absorption of dietary cholesterol is so variable. On average, cholesterol comes from two places, from what you produce and what you absorb. The majority of people, if they have issues with cholesterol being too high, are hyper producers and not hyper absorbers. That said, there are a subset of patients who are hyper absorbers where dietary cholesterol consumption does affect them pretty significantly. But the majority, what they're eating is not making significant impacts in regards to their cholesterol. It's what their liver predominantly is doing with regards to how they're producing and how they're clearing cholesterol. Saturated fat is really the target we've moved towards and away from dietary cholesterol. And the reason for that is because we have a better understanding that saturated fat consumption in excess directly downregulates what are called LDL receptors. Those are the receptors on your liver that are responsible for taking in, absorbing cholesterol from your bloodstream, bringing it to your liver for processing and potentially for clearance and excretion. So that's why we've shifted away from dietary cholesterol. And it's not to say don't worry about it, but the focus really isn't there anymore. It's focus on your saturated fat and trying to not eat in excess.
Perfect. That's good clarification. Dr. Hatzisisis, I'm going to give this one to you because you answered in our Q&A box one specific question about this. Please discuss the value of calcium score as a predictor of coronary artery disease and how frequently should it be done? And this one person asked, I had a 0 calcium score. Does that mean I'm out of the woods? I'm okay? And you answered?
The power of 0. There's no power of 0. I'm going to reverse the answer. Unfortunately, even 0 can be a widow maker sometimes, because 0 means that you don't have calcium in the heart arteries, but this doesn't mean that you don't have plaques rich in cholesterol without calcium in your heart arteries. And these are the plaques usually that rupture, as Dr. Bromley showed, under stress conditions, physical or emotional, and give us heart attacks, some of which might be lethal. So we have to be very careful to say that we're safe and we're out of the woods when calcium score is 0. It's a good thing as long as there's no plaques as well. But if we have plaques, we have to take care of those. And how we take care of those with all these lifestyle changes. And of course, if cholesterol is high and excessive, we need to address it adequately. And of course, calcium score 0 is good, but not necessarily out of the woods. And the higher, the worse. Usually we say that above 100, we start worried much. We need to engage more on lifestyle changes. We need to introduce aspirin. We need to introduce statins. And if it's more than 300, we need to be really, really aggressive with our statins. The dose of statins and the type of therapies is factor to the calcium score, and the higher the calcium score, the more aggressive we should be, the lower the targets in our bad cholesterol. Overall, these things should be in close collaboration and consultation with our cardiologists. And I would say it's very important that we consult the experts, the subject matter experts in these things versus Google.
Yeah. Thank you for that. And we're going to give the audience a bonus at the end of this, little surprise about the calcium score testing, which, by the way, should it be done yearly, annually, or?
We usually say every 5 years is adequate, unless there's an exception, a specific reason, but usually every 5 years is okay.
Okay. All right. Let's get to the question and all the commercials on television about natural supplements to take for our heart health. Do they replace the statins? Can they be an alternative to the statins, or can they be an adjunct? Dr. Bromley, I guess.
Yeah, that's it's a great question, and it's something that frequently comes up. So I think the biggest takeaway when thinking about cholesterol in regards to medications and or supplements is ultimately the goal should be get your LDL cholesterol to the goal that you've come to with the help of a cardiologist, your primary, a medical provider. My general stance on it is to use the least amount of medication at the lowest doses possible to get you to that goal. For some, particularly those with very high cholesterol, with cholesterol genetic disorders, that may take a number of medications 2, 3, an injection to get to that point. Others may not have very high risk and may not have very high cholesterol. And so those people may not need a cholesterol lowering medication in of itself to get to goal. There are things on a dietary front that lower cholesterol. Eating a lot of fiber, for example, in the form of oatmeal, of nuts, helps trap cholesterol within the gut and lowers cholesterol in a natural way. In terms of supplements, things like psyllium husk, which comes in like the form of Metamucil, for example, is a way to bind cholesterol within your gut and block it from being absorbed. Now, the cholesterol lowering you see from that is not going to be as robust as being on a medication. A statin can reduce cholesterol 30 to 60% in some instances. Psyllium husk is going to be far more modest, maybe 3, maybe 5, sometimes more percent, modest. There are other things like plant sterols. Those are things that we find naturally in nuts, berries, seeds, but also come in supplemental form that compete with cholesterol for absorption within your intestine. So you can supplement on those and again, get some modest benefit, 5% or so in cholesterol lowering. Certain people who are hyper-responders may have a more robust response. So it depends on how much LDL cholesterol lowering you need. If you've decided with your doctor you need a pretty robust response, 30 to 50%, not harm in considering supplements, but there are some limitations of what we can do with those.
Okay, let's talk about the magic pill that has been around for decades, aspirin, low dose aspirin. Is it still a go-to in your practice with your patients? And how does it translate exactly to heart health?
Yeah, it's a great question, and it's one that comes up frequently because it's often in the news, and it's one that has also undergone a change in school of thought. So statin or aspirin was something that previously, everyone was taking, was something we were talking about putting in the water because of how, beneficial it was. And the reality is decades have gone by, a multitude of trials have taken place, and a lot of data been had been processed and researched, and the benefit is fairly modest. Anytime you're taking a consideration of taking a medication, you have to balance the risk and the benefit in taking on a new medication, a procedure, a surgery, anything. Aspirin does thin the blood. It carries some inherent risk of bleeding. The benefit in taking an aspirin is that thinning of the blood and reducing the risk of blood clots associated with heart attack and stroke. The problem becomes how many heart attacks and strokes do you have to prevent or before you get offset by the bleeding risk that poses? That's where the issue in aspirin comes. So where we tease it out is also on a pretty personal level, and it comes from risk, which is not terribly surprising given the whole thesis of this talk. Those who are at higher risk, active tobacco users, diabetes, an exceedingly high calcium score, like more than 400 at certain points in your life. Those may be some risk enhancing features that signal out people who stand to benefit from taking an aspirin for primary prevention, those who don't have disease. That's distinct for those in secondary who have had heart attack, stent, stroke. That's a different group of people who they are likely on aspirin and probably need to be on aspirin in conjunction with their physician. But those
Dr.
who don't,
Bromley, if I can interrupt, is there such a thing as a preventative usage of aspirin for perfectly healthy people? Or should we?
perfectly healthy people, no, should no longer routinely be on aspirin if they truly are perfectly healthy. Now, seemingly perfectly healthy, but who have underlying significant coronary calcium and diabetes, who previously thought they were seemingly healthy or feel healthy, those are a different story. But if you really truly are on the basis of with a medical doctor healthy, you do not need to take aspirin for primary prevention anymore at this point.
Okay. And before I go to the next question, Dr. Bromley, some people are asking how they can be a part of the clinical trial that you just announced. Is it something that you want to drive people to your phone number and Dr. Hatsisisi's? Is that the best way for people to get in touch with your offices?
With regard to the trial, we're actually enrollment's not open yet. It's going to be starting to enroll in May. So hold tight for a few more months. But starting in May, do reach out probably to the phone number for our clinic. reach out with the intent that you're hoping to get involved in that trial, and we will get you into our clinic as soon as possible to be a part of that trial. But yeah, stay tuned for a few more months.
Okay.
But also, I would like to take the opportunity and highlight here the importance of being treated or being seen, because not everybody's a patient when you go to the hospital, by experts in an academic, comprehensive environment, because then you have access to people who not only know the field very well, but they do research. And by doing research, you go deeper and deeper, you become more expert. And of course, through this interaction, you have access to the latest medications, the latest technologies, because the mission of the university is to bring to this beautiful community the latest and the best to help our people live longer and better lives.
And Dr. Hatzis, let's talk about atrial fibrillation, AFib, which has become, I don't know, almost epidemic. There's so many, it's so common now. So what's the latest and greatest? Are we still talking about ablation, pacemaker? What's the newest way to treat it?
Yes, it's a little bit interesting as well, not directly related to high cholesterol, but indirectly related, because we have seen that obesity, high cholesterol, sleep apnea, AFib, hypertension, metabolic syndrome all go together. They share common pathways. And you see that the moment you start controlling better your obesity, you lose weight essentially, one way or the other, through exercise or through medications or through whatever means we have. You see that you have less episodes of AFib, less hypertension, less diabetes. So all these together are linked, and it seems that the common linkage here is extra weight, obesity. So we have a comprehensive AFib center in the University of Miami, the cardiovascular division, and we see our patients holistically. We don't only do ablations, which is the end of the spectrum of AFib. Question is what we can do before get to the ablation. Ablation is therapy. The question is what we can do to prevent. And prevention is to approach patients holistically, as I said, take care of the risk factors, their sleep apnea, their hypertension, their obesity, which is central here, and prevent the need to end to the bed in the cath lab and need ablation. Of course, if this needed, then we'll have to offer this therapy as well for symptoms, though.
I'm about to ask you a question on red meat consumption. It's like, you know, the cow is the bad guy, but I mean, I think any saturated fat is what Dr. Bromley talked about. But I want to ask this question since you talk about obesity. Are you all working in conjunction with endocrinologists as part of your practice with the GLP-1 drugs, which is now the miracle drug that everybody wants to be on, even to lose 10 pounds, which of course is inappropriate usage, but can we talk about that?
Yeah, so let me share in the limited time we have a couple of thoughts here based on evidence, not based on perceptions. Obesity and diabetes is the new pandemic of the 21st century. It used to be smoking, it used to be other things. At this point, our societies, especially this society in the US, tackles with diabetes and obesity, and they go together. And those two are the substrate for everything else: coronary disease, high cholesterol, high blood pressure, and so on. So they produce lots of cardiovascular mortality and morbidity, as we say. We need to control better our extra weight. By losing weight, we get healthier lives. And this can be done with exercise and lifestyle changes. This can be done with medications. Nowadays, we have new, modern, safe medications like the GLP-1 agonists. There's a variety of those which appear to be quite safe. And there's always side effects with medications, but the gain by losing weight exceeds this harm, these side effects. And of course, we have surgical options which are becoming less popular nowadays. So it's very, very important to have access to comprehensive centers like ours, where they can see our the subjects, the people holistically, and take care not only of the high blood pressure, but of the underlying pathology, which is obesity, which is sleep apnea, which is stress, and through nutrition services, which we have regularly in our prevention center, through endocrinology experts, through genetic experts, through psychology support as well, we can individualize a plan that will help our fellow human beings address all these pathologies. So it's very, very important to see things holistically, and that's what we offer. That's why I believe that every male, as I said, above the age of 40 and female above the age of 50 should have a checkup, because one way or the other, we encounter a cardiovascular issue, or we're in need for prevention of cardiovascular pathologies down the line.
All right, Dr. Bromley, I'm going to ask you to talk about red meat consumption. I know that it's part of saturated fats, so we're concerned about that and eggs and others, or just give us
Yeah,
a quick 411 on that.
yeah, absolutely. I'll start by saying I don't have the perfect answer, and I don't know that any of us know exactly what the right amount of red meat is. My 2 cents on it is one of moderation. I think everything in life should be approached through the lens of moderation. I really rarely counsel patients in my office that they can never have red meat. I personally enjoy red meat, so it's tough to think of not ever having something to look forward to and eating red meat. But it's
The quality of the red meat, Dr. Bromley,
yeah,
the grass-fed versus this or that, does that all matter?
I think it does, and the literature seems to support it does in terms of quality. So thinking about red meat in terms of how unprocessed, unrefined it is, meaning I'd much rather you have a grass-fed sirloin that's lean and relatively low in saturated fat consumption when compared to a more marbled cut of meat like a ribeye or New York strip, compared to ground chuck, compared to a hot dog or bologna, or for example. So if you're going to have red meat, make the choice to get the highest quality, leanest cut of red meat possible, grass fed, ideally as lean as possible. I think if you're going to do that, incorporate it in your diet and have it in moderation. The Mediterranean diet, which is a diet that we often point to as kind of the pillar of what a well-balanced, unprocessed diet looks like, even incorporates red meat a few times a month into that diet. So it's not one that excludes it altogether. It's just one that is not relying on red meat as the main protein source on a daily basis. Focus
Yeah.
on getting your protein sources from non-animal sources, be it beans, be it vegetables, be it fish, but try not to have it be red meat. That's where the problem comes in.
And I'm going to ask you both, since we're running out of time, because I knew we were going to need 2 hours for this topic. It's so chock full of info. In a world of blue zone countries such as Sardinia, Italy, where I just read a study, not only are they living longer, the cases of dementia are almost nil. So that's all cardiovascular, right? The heart, mind, etc. So take us home in 2025 tonight, doctors, and give us a happy take-home message about what the future is bringing and how positive it looks if we all try and do the right thing.
Yeah, I think if those blue zones are exceedingly interesting, and one that are under intense study at the moment. If you look at those blue zones, many of them share a number of tied risk mitigating factors that don't even take into consideration in mind. And it's things that when we talk about primordial prevention on that pyramid, those are people who are socially engaged. They have social support structures in their family, in their community, be it at church or an athletic association, etc. They try to avoid tobacco in most instances, but not all. They have really active lifestyles in that their communities are designed where walking is a normal part of life, to go grocery shopping or out and about in their daily living. Their quality of food, maybe not the exact component of what they're eating, but the quality and the way that it's raised, how local it is, how fresh it is, unprocessed it is, unrefined it is. They don't tend to be diets that are in excess. They are diets that tend to be rich in unsaturated fats. Those come in olive oils. Those are nuts, seeds, whole grains. Those are things that kind of tie those blue zones together. We're still trying to figure out what those are, but those are really what kind of lean us towards moving in that model of primordial prevention and not getting ahead of even tackling cholesterol and blood pressure, but thinking about how we structure society to mitigate risk up front in the entire way we structure our day and our lives.
Yeah. And not to mention, they're not on rush hour at commuting on I-95, right?
Definitively.
If you're in a beautiful
Yes.
island in Greece. But Dr. Hatzisi's, give us some nuggets of info to take home tonight with us, because this has been very eye-opening.
Yeah, first of all, again, it was a marvelous discussion here, very informative, and I was trying also to address very interesting questions from the audience. The couple of pearls here, very, very important to control our stress. We cannot live in a stressless environment, but at least try to have a steady stress every day, avoid the ups and downs abruptly, because this is when the body is stressed and can some plaques might rupture and give us heart attacks. Second, diabetes, as I said, obesity, they become a real pandemic nowadays. Focus on reducing our weight through exercise, through being careful with what we eat. We really need to be very mindful with what comes through our mouth into the body. It's our responsibility, and we need to be very extra careful with what we eat. And of course, sleep healthy. Sleep healthy without nightmares, because it's very important. This sleep hygiene is very, very important for the body to relax, recover, and get ready for the next day. So overall, control our weight, sleep well, try to control our stress, and that's probably the recipe to achieve better and longer life. And last thing, always refer to experts. Always be preventive, be proactive. Prevention is preferable to cure. Don't wait until it's late to seek for assistant help from a doctor. Be proactive, engage early, because prevention might save downstream future adverse events and heart attacks, and that's very, very important.
Yeah, Dr. Hatzisi's, thank you. And I think for those under primary care only that have some of these issues, you need to go see the experts. You need to see the cardiovascular teams, because that's what they're trained to do. And all you have to do is get your provider's referral, right? And to go into a practice such as yours, and that's it.
Of course.
All right, so now here's the surprise. Well, before we say goodbye to everyone, that we had in mind for the audience, since it is our Heart Month, February, we are extending a special to you, because it's the perfect time to get your calcium screening, see if you're a zero. UHealth is offering the way to measure the calcium in your artery walls and so forth, and that helps you determine your coronary heart disease risk. $25 only during Heart Month. So please take the online risk assessment to see if you qualify by scanning the QR code on the screen, or go to umiamihealth.org/heart screening. All right. Thank you all so much for being with us tonight. Our experts, for the privilege of your time, for your expertise, for your brain power. Thank you so very much. And our audience, thanks for being so proactive and participating and asking so many wonderful questions. As I promised, there's this stuff on your screen, the QR code to take you right to the cardiovascular team department. Here's the phone number for appointments, 305-243-5554. Gentlemen, good night. Everyone out there, stay healthy. Try and do the right thing. It's Thursday, and we still have one more day before the weekend. So be well, everyone. Stay healthy and well. Good night.